Good evening, Rekha Udani madam.
Welcome, Srinivasan sir. Very good afternoon to you. Welcome, Udani ma'am. Gitanjali ma'am, welcome.
Thank you so much. Good afternoon, everyone.
Thank you, ma'am.
Good afternoon. Yes.
Madam's favorite doctor, I have asked Dr. Nida ma'am to be the MOC today.
Yes.
Was
I'm
praising
happy she did so well. So I said you must take her.
today.
So privileged to have
कर लो मुझे फोन कर
hearing
लेना
the
फिर
praise
मदर
from
को
you.
चाहिए होगा तो मदर को रास्ते में ले
Wait a minute. Ma'am Udani, you have joined through two things. You have joined through two things and
ठीक
come out of one thing.
और
Have
I
you
have
joined on?
joined, but there is a problem.
काम और
No,
फोन
no,
They
come.
said I have to close the camera, and I don't know how to close the camera.
होगी गाड़ी पे
No, close the other one, ma'am.
ठीक
हाँ?
आप चले जाओ
Close the other computer से बंद कर दो या फोन से.
फोन से तो बंद कर ही दिया है.
नहीं मैम, दोनों चल रहे हैं और वो एको कर रहा है.
देख लो
कैसे करने का वो नहीं मालूम ना.
अच्छा, देखो
Good
आपके
afternoon, all
तीन
of
जगह
you.
से. जस्ट कम आउट ऑफ एवरीथिंग मैम. लीव, एग्जिट कर दो.
हाँ, एग्जिट कर दो.
हाँ.
ओके, एग्जिट करके फिर से जाऊं.
हम्म.
ठीक है, इसको तो मैं बंद कर देती हूँ.
How was school today? Good. Is it good because you achieved first sleep action? Or is it generally good?
Ma'am, please exit. There are three of your. You are joined from three. This thing. So sorry to tell you. Let me give you a call. Wait. Attend to my.
Nita ma'am. Nita ma'am.
Yes, sir. Yes, sir. Yes.
If Dr. Vinod Paul sir does not join in the beginning,
Okay.
you just introduce madam and let her speak, and then you introduce guest of honors directly. Because Vinod Paul
Okay,
sir
sir.
may join little later also. Don't know.
I will have to keep checking the
Just
participant list.
okay. Just see, or if he comes, I will say welcome, Dr. Vinod Paul sir.
Yes, sir. Please.
Yeah.
Good afternoon, Rupa ji.
Good
Good
afternoon.
afternoon. Good afternoon.
How are you, sir?
Rupal, very good morning to you. It's middle of the night. You are there.
Yeah, it's 3 in the morning.
Yeah, I don't know. I think there was a little confusion. My apologies. I
Yeah,
thought it is the other Rupal. So he had already said
yeah,
to you. So you're disturbed, whatever. But are you okay?
yeah.
Free to be there?
Yes. Yes, I'm okay.
Yes,
I'm
sir.
okay.
God
Yeah.
bless you.
Thank you
God
so much.
bless
Thank you so much. Yeah.
Afternoon, Neelam ji. How are you? Hello,
you.
Neelam.
Very good morning, Dr. Das. I'm very well. How are you? How's the
But ठीक ठाक.
water?
Just coming from the program, we had the final day with 170 participants from NGOs and doctors
Very good,
from
sir.
medical college.
How,
We'll be
at
sending
least
it.
picture bhej do, jana we will put it in the magazine.
Right. We'll do that.
Please send
We'll
the
do that.
pictures. Okay, sir.
Okay, bye.
Hi, Dr. Neelam. Dr. Bapai this side.
Sorry, I missed. Who said hi?
I'm Dr. Charulata
Oh,
Bapai.
hi, Charu. How are you?
Hi.
I
I'm
was
very
just
fine. Thank
admiring
you.
your pictures.
Ma'am, Charu
Hi,
madam
Charu.
Madam Charu madam has helped a lot during all this.
Yeah, I know.
She was from
She
top.
has been a delight, a delight. He
No.
mentioned to me that she will do all the needful.
Yeah, that's fine.
Dr. Ruchi, what we will do is आप start करेंगे welcome से, then we will I'll give a message. Ruchi, are you there? I think you can hear me.
Ma'am, Ruchira ma'am is supposed to go to
Yes,
some.
I'm here. I'm here.
Okay, so I
Yeah.
saw her. That's why I said welcome दे देना Ruchi, and
Yeah,
then
ma'am.
I'll take it. And
Sure, ma'am.
लालन या जो भी आएंगे डॉक्टर पॉल तो तब मैं उनको बोल दूंगी and आवाज लालन to introduce us. It's short. Everybody
Sure,
knows.
ma'am.
So,
Sure, ma'am.
Lalan, thank you, sir.
Sure.
Hello, Ruchira.
Everybody, please start
Hi,
posting.
sir. Namaskar.
How are you? ठीक ठाक.
I'm all right, sir.
Okay.
Lalan has joined. Great.
Good evening, President Madam. Good evening.
Very good evening. Namaskar, कैसे बोलूं, sir? Thank you. Sushma, very good afternoon to you. And
Jai Shri.
Good evening, Madam.
very, very good evening. There are two equipment somewhere. One will have to be shut.
Yeah. Good afternoon, Dr. Neelam.
Sushma ji, very good afternoon. So lovely. Asha ji is there? I can't see Asha.
I'm sure she'll join in a minute or two.
Yeah, because Dr. Chedu has joined. The panelist.
I'm Dr. Taru Chaya from Jaipur.
Okay, great.
Hello. कौन ज्वाइन हो गए मैडम? अच्छा, ओके. नहीं, ये मैंने बोला है निदा को पूरा सीवी दिया है.
I think we can go live, Saji. Is there anybody from the EB team? Anybody from EB?
Ma'am, we'll just going live.
Saji, EB में डाल दो that EBs have not joined.
This session है क्या? और ये सब तो होता है.
Ma'am. Madam?
Yes, please.
Dr. Nida Madam is initiating the proceedings. She will call Ruchira Ma'am and then.
Okay. We've gone live. Sajid, we've gone live.
Yes.
We've gone live. Okay, start.
Good afternoon, everyone. Yet another episode of an exciting series on breastfeeding, promotion, and the science being organized on this World Breastfeeding Week by an alliance of IAP, NNF, FOXY, and INC. Today's topic is breastfeeding milestones, breastfeeding in preterm babies, low birth weight, and perinatal conditions. May I have Ruchira ma'am to give her welcome address.
Thank you. Thank you very much. It indeed is a proud pleasure to welcome you all on this World Breastfeeding Week, which we are going to conclude today. And we'd like to appreciate our President, Dr. Neelam Mohan, for this noble initiative, along with the presidents of FOXY, NNF, and Indian Nursing Council for being together and taking this initiative forward. Dear friends, I just want to say that this week is concluding today, but 1 week of celebration should become 365 days of commitment. With this, I wish you all a very happy day and a happy breastfeeding week. Thank you very much. Over to Dr. Nida.
Thank you very much, ma'am. Now let's invite our...
And 1 minute, I wanted to welcome our chief guest, Dr. Paul, as well as guest of honor, Dr. Jayashri and Dr. Rupa Bellar. It indeed is a pleasure to have them, and we are very proud of them joining us. It is our privilege for their joining. Thank you very much.
Definitely, ma'am. We are so proud to have them on board today. Now, may I request IAP President, ma'am, Neelam Mohan, ma'am, to continue the session and invite our chief guest.
Hi, good afternoon, everybody. It's indeed a pleasant day also today that at least the weather in the Delhi is very beautiful. I think the gods and the angels are also celebrating with us as we celebrate this breastfeeding alliance, which we've called as the Indian Alliance for Breastfeeding Action. Deliberately, we use the word action because we just don't want this to be an alliance, but we want to do action. And as we have seen in the last 6 days, we gave a gamut of the various issues and the thing that we need to talk about breastfeeding. And today itself in the presentation, you will see that there are so many things that we pediatricians, we often think that we know, but we do not. And what is it that needs to be there for every pediatrician to adopt? Because it is something which every healthcare worker should be understanding about breastfeeding so that in uniformity, we are able to give one voice to the entire country. And this alliance is very grateful to our beloved presidents of the association, Dr. Bhaskar Rai, who's the FOXY president, Dr. Lalan Bharti, who's the NNF president, and Dr. Dilip Kumar, who's the Indian Nursing Council. In addition, besides that, we did have the public health experts as well as the Neonatologist Nursing Association and the Trained Nursing Association. These three also joined together when we were speaking along with the Global Health and the Bill Gates Foundation when we came out with a joint statement which is going to be disseminated about the basic 4 recommendations. We know the policy exists, but why is the policy not translated to clinical sense? So these 4 recommendations, and in the 4th one, it talks about the mental health too. So while we talk about the early breastfeeding, while we talk about need for exclusive breastfeeding, we also address the mental health concerns in the 4 recommendations that we came up to. But this alliance is going to be spreading the information far and wide. join. And today, to be for the chief guest, we had none other than Dr. Vinod Paul. Has Dr. Vinod Paul joined? Dr. Ganesh, can you see him? And he has been instrumental, not only being the HOD of the institute, one of the premier institutes, AIMS, and as the professor. And then he moved on to Niti Aayog, where he became a prominent public health expert, a pediatrician who talks about this. And he is going to talk about we really reduced the neonatal mortality under his leadership in Niti Aayog. And now the bottleneck seems to be if we are able to see how we address the preterms, the low birth weight, which constitute a major proportion of the deliveries, more than 23 million deliveries annually in India, and a significant proportion is the preterms and low birth weight. How do we address them is the theme of today's topic that we will do. And also what is interesting is that as we go, I am very happy that we have Jayashree as there and Rupa, who is the IYCY chairperson. She's also joined as a guest of honor today. And we'll discuss the panelists subsequently. And in case Dr. Vinod Paul joins anytime, Dr. Ganesh Kulkarni, he was in the ministry. He sent me a message that he is going to be joining. So when he joins, we will take his address because I'd asked him to join at 3:40 to 45. In the meantime, till he joins, we can welcome the guest of honor, Dr. Jayashree Monkar, to maybe even Dr. Rupa is traveling, so she requested if she can give her message. So maybe if Dr. Vinod Paul is not there, we have first address with Rupa Bella.
I'm here, madam. Thank you. Can you hear me?
Yes, we
Yeah.
can hear you,
Good.
but we can't see you.
Good afternoon and respected President Madam Dr. Neelam and all the other presidents, NNF, FOXY, in Indian Nursing Institution. Thanks for welcome. For asking me to be here, and this initiative, what you have taken, would go a very long way. That's what I feel, and thanks again. All the best for the activities. Thank you.
Thank you so much. And over to Nida to invite the second guest of honor, please. Because she had to travel, so I had to go.
Neelam ma'am, thank you very much. So let me introduce the second guest of honor, Dr. Jayashree Monkar. She is Professor Emeritus and retired Dean and Professor, Head of Department Neonatology, and in charge of Human Milk Bank, retired from Lokmanya Tilak Municipal Medical College, General Hospital, Sion, Mumbai. She is currently Trustee Society of Nutrition Education and Health Sneha for Women and Children, and she's Chair NNF Accreditation Committee. She has also been a member in the past for Technical Expert Committee of Department of Biotechnology, and she has over 92 journals and chapters contributed are around 32. She has multiple awards, and the latest one being Rotary Award for Excellence, and which was given to her in 2015. She has attended and organized multiple conferences and workshops and on neonatal ventilation, neonatal resuscitation, breastfeeding, and milk banking. She is also organizing secretary for annual National NNF Convention 2000. Such an eminent personality, we are honored to have you here, ma'am. Dr. Jayashree, ma'am, welcome very much.
It's a very good afternoon to you all. And I must say it's a pleasure and a privilege to be part of this National Breastfeeding Alliance platform today. And kudos to Dr. Neelam Mohan for coming out with this idea. And of course, kudos to all the presidents and the office bearers of the various four organizations who have come together on the same page. Today, since we are focusing on preterm, on preterms and low birth weights, I thought I would, sort of put together a few actionable, actionable points as far as these preterms are concerned. As we know, our basic goal or our basic objective for these preterm babies and these low birth weight babies is, like their term counterparts, they should also go home with, breastfeeding they should leave the institution breastfeeding or at least on their own mother's milk. And this holds true even for the extremely preterm babies, the very preterm babies who may stay in the unit for sometimes as long as 2 to 3 months. But our goal, our objective should be that these babies also should go home on their own mother's milk and ideally breastfeeding. So just to put down a few, action. I mean, this is not something that is very simple. It takes a lot of effort, and it takes a lot of effort right from the word go. So the actionable points that I would like to suggest, that we need to strengthen. We all know them all, but something that we need to strengthen. The first thing is that for all term low birth weight and SGA babies, the larger preterm babies, all those babies who are, cry immediately at birth, just like our term counterparts, they also should be put in immediate skin-to-skin contact, and we should allow them to, do the breast crawl. Of course, we need to ensure that they do not get hypothermic in the process. So after the initial, stabilization is over, we should dry them. We should cover them with a warm blanket, and ideally should be supervised at least by a resident. Then this whole group of babies that I just talked about, we should encourage them right from day one to be put to the breast and breastfeed. Of course, they may not be able to get their whole requirements that would help maintain their blood sugars. So periodic blood sugar monitoring by the nurses, trained nurses on duty or by the residents is important for these babies. We need to understand that sometimes there would be a proportion of babies who would require additional feeds to be given. Now, talking about those babies who are admitted to the NICU, so the VLBWs, the very low birth weight and the extremely low birth weight babies, here again, the action starts right from the word go. So these babies, it starts with first and foremost, free entry of mothers into the unit. 24/7 mothers should be, this is, since I've worked with Dr. Fernandez, this has been age-old practice for us. But 24/7, these mothers should be allowed to enter into the unit, participate in the care of their baby, and most importantly, express their breast milk in the unit so that they can provide their own milk for their babies. Now, when we talk of expression, the important point is that all mothers have to be supported and taught how to do manual expression of breast milk. That is the second actionable point, and this has to be done by the lactation counselors, by the nurses on duty, the residents, the consultants. All of us should be helping them so that they learn the appropriate technique of hand expression of milk so that they are able to sustain their milk supply. The important thing is at least we expect them to express milk 8 times in 24 hours. That's what we would encourage them to do. And what is also very important is that we should, so the message should go very clearly that even if your baby is on minimal enteral nutrition, even if your baby is on nil by mouth, you need to express from both the breast, complete expression of milk so that they can, it helps to sustain the milk supply. Then, of course, a special mention of LSCS deliveries, because in preterm births, the large majority are LSCS deliveries. So in such a situation where, when Mohammed can't come to the mountain needs to go to Mohammed. And here it means that the lactation counselors or the lactation nurse or any nurse who is dedicated to helping mothers to feed should go to the bedside of the mothers, help the mothers actually in colostrum expression, drop by drop, collect it with a syringe, and then should transport it safely to the under cold chain to the neonatal intensive care unit, where it is used for feeding and for those babies who are not on feeds for oropharyngeal coating of milk. After that, of course, kangaroo mother care is very important. Then escalation of feeds, and today we have robust evidence from our own country that for preterms between 1,000 to 1,500 grams, if they're stable, they can actually be put on full enteral feeds right from the day one. Now here mother's milk may not be available in the volume, and here is where milk banking plays a role. And today the national accreditation for level 3, one of the mandatory criteria is that the unit has to have a milk bank or an affiliation to a milk bank. Then, of course, kangaroo mother care is very, very important. That would help to sustain the milk output besides, of course, all the other benefits. And in the convalescent phase, non-nutritive sucking and oromotor, assessments and interventions with the help of the occupational therapist or by the trained lactation consultants helps to reduce the time to sort of, move from gavage feeding to oral feeding. And baby should be, of course, growth monitoring, fortification and all those things are equally important, have to be there throughout the whole course. And babies should be discharged only when they have learned to latch on the breast. So by the time these tiny babies are ready to go home, mothers really get very anxious and they want to go. The last phase becomes the most tough for them. But we need to ensure that the baby has learned to latch on the breast before we actually send these mothers home, because then the success of breastfeeding post-discharge will also be there. And lastly, of course, they need to be called back for an early follow-up to see that the entire transition, including feeding, has been done, and repeated follow-ups where again feeding and growth monitoring is done. So this is in a nutshell what would be the preterm, what would be the actionable points for preterms to ultimately go home on successful breastfeeding. Thank you for the patient listening.
Thank you so much for that. That was very lucid, that the way you covered. And I think, though we discussed other things, but regarding the expressing of milk, there are a lot of myths and a lot of concerns in the country. And I would expect the subsequent, when we take the panel discussion, for people to give more clarity in the expressed breast milk, because I'm very happy. It is not only for the preterms, but sometimes we are stuck with the regular situation, which we need to address it. Dr. Lallan, I have a message from Dr. Paul. He is just chairing a session. May I request you for an address? I know you were supposed to address when he joins, but since he's taking time, I would be sincerely appreciative. Dr. Lallan Bharti is the president of NNF. And when we talk about the preterms, it is so important that the neonatologists are the ones who actually face the brunt, and they should be coming out with the guidelines, which are pretty clear for low birth weight separate, for preterm separate, preterm from 32 to 34, less than 30 to 22. So these guidelines, what you have come out, if any, we would be happy to hear your thoughts as the president of NNM. Thank you.
Thank you, Dr. Neelam. So before I answer your question, let me first congratulate you on the phenomenal work you and your team have been doing this year for the cause of children, and your leadership and commitment to the child health are truly commendable. Kudos to you and your team. So coming to your question regarding the prematurity, so prematurity and low birth remain one of the leading cause of neonatal mortality. So the most important message is that the management of prematurity doesn't begin in an ICU or with the pediatrician. So it begins during the pregnancy with our OBG colleague. Early identification of mother at risk of preterm birth, timely administration of antenatal corticosteroid for lung maturation, then magnesium sulfate for neuroprotection, and evidence-based perinatal care can significantly improve outcome even before the baby is born. And another equally important aspect is in utero transfer. So whenever a facility doesn't have adequate neonatal intensive care services, the mother should be transferred before delivery to an appropriate center. This is very important. And once the baby is born, especially if the preterm or low birth baby, mother's own milk become the next life-saving intervention. So human milk is not just nutrition we all are discussing, it is medicine, especially for low birth and preterm baby. It reduces sepsis, NEC, feeding intolerance, and also improve the long-term neurodevelopmental outcome. And along with this breast milk, another very important intervention is kangaroo mother care, right? And so this will provide not only the breastfeeding, but the warmth, bonding, improve, significantly enhance the survival and for this baby. So that's why no single specialty can achieve this alone. So it requires the obstetrician, pediatrician, nursing colleague, and lactational counselor working together across the entire continuum of the care. So at NNF, we have been working in the same direction. And in collaboration with the Foxy, we had launched perinatal synergy. So I'll take to discuss that also. Following a neonatal training of trainers, several joint workshops we have done across the country. And we have also launched India's first structured national neonatal transport training of trainers for stabilizing the safe transport of the sick newborn baby. And when postnatal transfer become very difficult, the transport has to be taken into the consideration. Government is also working on that. And to promote and protect the breastfeeding, we have started a evidence-based lactational management course this year. And we had already 500 healthcare professionals and doctors are going to be trained in that. So today's Breastfeeding Alliance beautifully reflect this shared vision of all of us, from pregnancy to safe birth, to optimal newborn care, and finally successful breastfeeding. So together we can ensure that every preterm and low birth baby not only survive but thrives. So my one message that is very simple: the journey of the saving preterm baby starts before birth. But one of the most powerful therapy after birth remains mother's own milk and KMC. Thank you, Dr. Neelam, for giving me the opportunity.
Demental, and I think I congratulate you for this, the India's first neonatal transport training. That is very fun, and we would be very happy once the document comes to distribute it to all the pediatricians on your behalf. We shall share that. And in addition, we shall be happy that we will also share the evidence-based lactational course. And it was a very coincidental thing that 2 days back, not that I knew about this, but I was telling Dr. Ganesh and Dr. Sushma Malik-Ashad that we should have a course which is able to start on the Digi Academy, and I asked them to start somewhere in October. And hopefully, we will be able to take some guidance with you and shall duly acknowledge the same with that, because let them prepare something and then you can be an editor to check what it is, and you will be the official editor to check onto that. So that we are going to do this on the platform which I had just was 2 days back to Sushma and to Ganesh and Asha. So I think we are waiting for the numbers to come together. I am seeing that those who are interested and attending the whole days, the 7, we have an idea who are dedicated into this, because one has to be very passionate about doing. And what I want to say to some of my breastfeeding experts, that please understand that there is a separate role for a lactational counselor, there's a separate role for a pediatrician, separate for a neonatologist. It is beyond the scope of a pediatrician to be updated on all the skills of a course which goes, the lactational experts with training can go months and months into that. And those who do nothing except breastfeeding support, we cannot compare every pediatrician to that. But since it is something which is the birthright of every child. We would need a battalion of people to look into it with the 23 plus million deliveries annually. And we will need all the pediatricians and the healthcare experts, the nursing people, some of the neonatologists who are interested can also take a branch. And yesterday, the last 2 days back, we were so impressed that in the Foxy, there was an expert who was only in lactational she's doing. So we need to understand that when we are conveying things, we need to make it very simple so that every pediatrician is able to do, and we cannot compare the knowledge of what there are. There's 1 week courses, 10-day courses of IYCY, which cannot be translated. But the course that we are going to start on Digi Academy is going to be something which is simple and universal and needs to be trained for all. So that way, why message do we have? Dr. Bhaskar available here? Dr. Bhaskar, are you there? Right. Dr. Dilip, are you there? Right. Since those are not there, I would request now that we can proceed with Nidam. We will have a talk in the 10 minutes, but we have the panelists joining in the next session. And Chinmay, I was very unhappy to say that we have Chinmaya, a young budding pediatrician, and this is what we wanted to give the message to all. Not that we wanted to undermine the role of consultants today, but just to have Chinmay was just to say that it is time that the youth needs to also take in the responsibility. So though Chinmay is a senior resident in Bangalore, we just want that he should be like a torch bearer who should communicate with all the other postgraduates and the senior residents who obviously have not joined this forum. But we are happy that today we chose, instead of a consultant, a young budding senior resident who is obviously a pediatrician because he's a senior resident, but he is holding the torch, and he would give a glimpse about the issues related with breastfeeding milestones, breastfeeding in preterm, births, low birth weight, and perinatal. And subsequently, we've formulated the question, and he has been handheld by the mentor. And I'm sure Dr. Asha and SMA have looked into the question, which even I supervised the question. So I'm very proud to introduce Chinmay, who can share his slides and present in the next 10 minutes on this. Thank you, Chinmay.
Good afternoon, everyone. Am I audible?
Yes, please.
Yes. Good afternoon. A warm welcome to all the esteemed faculty members, delegates, my dear colleagues who are live today. Today's session, we have some exceptional panels, experts who are very pioneer in their field. So our panelists for the day are Dr. Ramesh Agrawal sir, Dr. Prashant sir, Dr. Charulata ma'am, Dr. Rupal ma'am, and Dr. Gitanjali. So Dr. Ramesh sir, he is a renowned academician, clinician, teacher, researcher with women's contribution to the field of neonatology and newborn care. And he has been excessively working towards the neonatal care, the preterm and high-risk newborns. Coming to our second panelist, Dr. Charulata ma'am, who's a consultant obstetrician and endoscopic surgeon, and she's a director at GEMS Hospital, Pune, and she's also a member of Breast Health Committee. Our third panelist for day is Dr. Rupal ma'am, who is a team leader at Health Spoken Tutorial Project at IIT Bombay since 2007, and she has been created 105 skill-based tutorials. And our fourth panelist is Dr. Prashant Kumar sir, who is a professor at SUM Medical College, Bhubaneswar, and he has been holding various positions in IAP over the years. And our final panelist for the day is Dr. Gitanjali ma'am, who is a nursing faculty at National Institute of Nursing Education, PGI, Chandigarh.
Dr. Chinmay, can I interrupt? I think Dr. Taru Chaya is also a panelist from Foxy. Or you don't have details about her? Dr. Taru, are you here? Well, maybe there was a miscommunication. That's okay. You can continue, please.
Yeah. Coming to my today's topic proper, that is breastfeeding milestones and special populations. Uh, what we'll be learning through the session is we'll be able to trace the milestones, judge adequacy objectively, adapt to the special populations, separate myth from contraindications. As we all know, recently we have the National Family Health Survey has been released, which shows that the institutional rate has been raised from 88% to 91%, and the saddest part is that the exclusive breastfeeding for the first 6 months has dropped from 65% to 55%. Um, the four recommendations which has not changed in the last 20 years is that initiate within the first hour, exclusive breastfeeding for 6 months, complementary feeding from 6 completed months, continue breastfeeding to 2 years and beyond. So coming to the topic proper, the breastfeeding milestones. Uh, the milestones at a glance, it begins at the mid-pregnancy at 16 weeks of gestation, where there is secretory differentiation and alveoli is capable of making milk. And the first 60 minutes, the breast call and the first latch happens. And 30 to 72 hours, the secretory activation happens where the progesterone withdrawal switches on to copious milk. The volume rises sharply by day 3 to day 5. And from day 10 to day 14, we have the birth weight, which has been regained. And the 6 months is exclusive breastfed. And up to 24 months, the feeding has been completed. Coming to the mother's milestone, the lactogenesis, 3 stages. The stage 1, the secretory differentiation, which happens from 16-week gestation up until birth. And the clinical marker here is the breast enlargement, areolar darkening, Montgomery tubercles, occasional leaking. And the stage 2 is the secretory activation, which happens at 30 to 72 hours after delivery of the placenta. Here, the clinical markers are breast fullness, warm and heaviness, audible swallowing, stool turns yellow. Galactopoiesis is the third stage, which happens on day 9th onwards. The clinical markers is settled feeds between settled breast between the feeds, and the first hour of life, that is 9 instinctive stages of which all we know how it works: the breast cry, relaxation, awakening, activity, rest, crawling, familiarization, sucking, and sleeping, which we have discussed in detail 2 days back in our session. The colostrum, which begins at day 0, where it is minimal 40 to 50 ml over the whole day, which is the volume is small but not in failure, which is dense in secretory IgA levels, lactoferrin, leukocytes. And the transitional phase, which is day 5 to day 14, where the volume rises steeply as the immunoglobulin concentration falls. The fat and lactose climb, energy density increases. The mature milk is on day 15 onwards, where the volume is 700 to 800 ml per day and roughly 65 to 70 kilocalories per 100 ml. What are the parameters we have to look on the daily basis, like from first week to second week? I mean, the feeding, which happens in 24 hours, the number of wet nappies, the stool color, and the stomach capacity and the weight. So when you have to reassure, when it is more than equal to 8 feeds, more than equal to 6 heavy nappies, and more than equal to 3 yellow stools daily from day 5, with audible swallowing and a settled baby after the feeds. A small note on Q feeding. It is the way of babies asking for feed. The pointers, like baby should feed the baby when the mother should feed the baby when baby seems to be hungry, because the baby's stomach capacity is very small and the human milk is easily digestible. These are the cues: early cues, mid cues, and late cues. So the weight trajectory, usually the weight falls, the birth weight falls on day 3 to day 4. We should not panic at it. And loss up to 7% is physiological. Loss beyond 7% is when we have to observe a complete feed, transfer, latch, and start the feeding. Coming to the baby's milestone, mainly we have to worry on the 28 to 31 weeks where the non-nutritive sucking starts, and the 32 to 34 weeks where the nutritive sucking emerges. That is when the suck, swallow, breathe, the coordination happens with 1:1:2 ratio. Coming to 0 to 6 months, holding exclusively and proving it is working. What to do? We have to focus on the Q feeding 8 to 12 times in 24 hours, nothing but breast milk, and expect 40 to 45 gram weight gain per day in first 5 weeks. Then onwards, it comes on to 20 to 30 grams per day. And the growth spurts happen around 3 weeks, 6 weeks, and 3 months. Uh, as we all know, 6 to 24 months, the complementary feeding alongside the continued breastfeeding. So the complementary feeding rules, we all know it depends on the feeding frequency, amount, thickness, variety, active feeding, and hygiene. When a milestone is missed, we have to recognize it early and then act in a fixed order. What the response should be: the observe a whole feed, correct the position and the attachment, start expression immediately, feed the baby with mother's own milk, wait, review, and follow up. This is a summary of the breastfeeding milestones. Coming to the second part of the talk, that is breastfeeding in special populations. What we have to look after is we have to assess, we have to find what the actual barrier is, we have to enable, we have to remove the barrier without losing the milk, and we have to sustain. The preterm and low birth weight, what WHO 2022 and NNF guidelines actually say, that we have to feed from the day one. We have to feed only mother's own milk and donor milk when it is not. When mother's own milk is unavailable, donor's milk may be used, including for very preterm infants. And kangaroo mother care is the routine care, and fortify and supplement selectively. NNF supports multi-component human milk fortifier for infants under 32 weeks or 1500 gram. The preterm practice, the feeding ladder, always the less than 28, we all know this, less than 28 weeks, the parental nutrition with minimal enteric feeds. 28 to 31 is the orogastric or nasogastric feeds. 32 to 34 is introduction of palada or katori spoon cup feeds, and more than 34 is direct breastfeeding. Coming to the multiple gestation, twins and triplets, supply is rarely the limiting factor. The physiology is on your side. Milk production responds to the removal of the milk, not the number of babies. Mothers of twins routinely produce for two or more, two, and mothers of triplets for three, provided the breasts are drained frequently and effectively from the first day. Expect the preterm overlap. Simultaneous feeding saves the day. Rotate the breast. Support the mother, not just the babies. Uh, the oromotor and anatomic challenges: when the baby cannot generate or sustain an effective seal, the cleft lip, cleft palate, tongue tie, hypotonia and Down syndrome or neurological impairment. The unwell newborn, the illness is not a reason to support breastfeeding harder, not to stop it. Like, for example, in case of jaundice, there is breastfeeding jaundice, which is caused by underfeeding. The treatment is more feeding, 8 to 12 times a day, not less than that. Breast milk jaundice is benign and prolonged. Here, you have to continue breastfeeding. Phototherapy is not a reason to interrupt the feeding. Do not give water or dextrose orally. And hypoglycemia, you have to maintain the skin and skin contact and initiate early and frequent breastfeeding. Congenital heart diseases, breastfeeding is less physiologically stressful than bottle feeding. And here, kind of short, frequent feeds, express milk top-ups, fortification when calorie requirements are high. And in inborn errors of metabolism, like classic galactosemia, phenylketonuria, maple syrup, urine disease. The maternal condition that need a plan, not a prohibition: the cesarean birth, diabetes or gestational diabetes, obesity and PCOS, previous breast surgeries, insufficient glandular tissue, flat or inverted nipple, mastitis and breast abscess, maternal mental health. Maternal infections, very few infections we need to stop breastfeeding. Mostly change is only the precautions. So we know all these infections, we come across them: HIV, tuberculosis, hepatitis B, C, herpes, COVID, and cytomegalovirus. And breastfeeding, stop breastfeeding is almost always the wrong first answer when it comes to when the mother is on certain drugs. Like, what are the principles for choosing? We should prefer a short half-life, which has less accumulation in the infant between the doses, prefer high protein binding, prefer low oral bioavailability, time the dose, adjust for the infant, and check before you stop. Restarting and continuing, relactation, induced lactation, and the mother who returns to work. So relactation, restarting after breastfeeding has stopped, feasibly works to weeks to months later. How is the method? Continuous skin to skin, sucking 8 to 12 times a day, supplementary sucking by fine tube at the breast or palata top ups. Milk usually reappears in 2 to 6 days. A full supply takes 1 to 4 days. And in induced lactation, that is for adoptive and non gestational mothers, and in surrogacy, uh, a supplement nursing system delivers donor milk or formula at the breast while supply builds. And the working mother, we have a paid maternity leave under the Maternity Benefit Act and the Crunchy facility. Build a store, feed directly before leaving and returning. Express every 3 hours at work. Send express
We
milk to
need
the.
to proceed, dear. We have to get into the panel, please. Let's
Yes.
move on.
The short list when the breast milk genuinely must be withheld is absolute indications, that is galactosemia and inborn errors. Absolute maternal indications are HIV infections, and temporary is the herpes simplex lesions on the breast. And the system level intervention with the strongest evidence is the 10 steps to successful breastfeeding, the MA initiative, a dedicated lactation counselor, IMS Act, human milk banks, and maternity protection that is actually used. The key takeaway, 6 things to carry back is the milestones are the observable and time bound. The first star belongs to the baby. Small volumes early are normal, and preterm feeding follows maturity, not the calendar. The list of 2 contraindications is very short. Support is the intervention. Thank you. I think now we'll proceed with the panel discussion, the panel questions.
That was very wonderful. Thank you, Chinmay. We just wanted to give a brief on this, and the panel is going to be Dr. Ramesh. Have you joined? Dr. Ramesh?
Yes, Dr.
Okay, great.
Yes, Dr. Neelam. Good
So,
evening to
Chinmay,
everybody.
you can start with questions for Dr. Ramesh from there. Thank you.
On the panel discussion, the first question, sir. Many NICUs differ in deciding when a preterm baby is ready to transition from tube feeds to direct breastfeeding. What clinical signs and milestones do you personally rely on? And what are the common mistakes young doctors should avoid during this transition?
Chinmay, you nicely shown the gestation-specific transition from tube to palatal to breastfeeding. That up to 31, 32 weeks you do tube and then palatal up to 34 weeks and then direct breastfeeding. Which is fine. The only thing that I would like to say is that the breastfeeding inadequacies, and you were talking about calendar and maturity, the same principle applies here also, that you cannot go just by gestation. So make sure that when you are transitioning, you assess adequacy of breastfeeding, because when you shift from tube to palatal, often the babies are not able to accept enough amount of milk. So therefore, be ready to supplement with tube while you are proceeding to palatal. And same way, when you are proceeding from palatal to direct breastfeeding, then also you might have to continue supplementing with palatal. That is the most important thing that you need to keep in mind. Regarding the competencies, the palatal does not require coordination with breathing, so therefore you can feed them earlier. Breastfeeding would require, so therefore ability of the baby to accept feed by these alternative methods, and that direct breastfeeding should be assessed carefully. But more than anything else, the weight gain adequacy would be the most important parameter.
Thank you, sir, for a valuable insight. We have a second question for you, sir. If you were to redesign a neonatal care in India today without resource constraints, what 3 changes would you prioritize to ensure every newborn, particularly the most vulnerable, receives optimal breastfeeding support?
I think the resource constraint is a reality. Let's not ignore that. That's point one. And then secondly, it's more important than resources. I think it's the mindset, and then the way we think. I think a couple of things are very, very important, that often we tend to gravitate towards the technology and think that's the solution for the problems that the neonates face or we face. To me, intensive care, if you are talking about intensive care, you though are talking about, redesigning neonatal care. So therefore, I presume that, it's at all the levels. So let me let's not talk about the neonatal intensive care. Let's look at the broad design at all the levels. So the defining principles would be that the family should be, it's not the baby. I think that's the paradigm shift that we should have in our minds, that it's the mother and the baby and the family. So I think that should be the most important thing, and the care must begin from the antenatal period and possibly before that. Unless you take care of the mother, the outcome of the babies cannot be better. The second thing is that the majority of the deaths that happens during first 24 hours or during first 72 hours. So therefore, the care during this period becomes very, very important. And we need to make sure that we get the basics right before we talk of any technology. Technology is not the solution. Yeah.
Thank you so much, sir. Moving on to
Just
the
hold on. Thank you. Rakesh, what I wanted to ask in this particular question, when I said if you were to redesign neonatal care today, um, uh, I personally feel that the enthusiasm that you see now in the government, once we are moving towards Viksit Bharat, so the entire focus is on the first 5 years, and people have understood the importance, and people have understood, I mean, in the administrative side, the importance of breastfeeding and to reduce the mortality. So my question is specifically in the sense, if you were at that post, what is the changes in the sense? Now, would you want to, what is the total cohort of preterm births in the country? Like we know it's 23 million or 24 million a year. What is the preterm total cohort which are there less than 32 weeks?
So you see that preterm in general forms 13% of the total population. So let's say we have 25 million babies being born. So we would have approximately 4 million of them being preterm. And 80% of these babies are late preterm, not the ones below 32 weeks. 32 weeks population, if you look at the community level, then that's not likely to be more than 1 to 1.5% of the total births. Approximately 10 to 15% of the total preterm birth. Just to reiterate this, because I have told too many numbers, that of 25 million births every year, we would have approximately 4 million babies preterm and 1 to 1.5 lakh babies being less than 32 weeks. So that's the kind of burden that we are facing.
So my question to you was, if this is like, it is true that it is usually less than 32 weeks that you will have issues using the breastfeeding, and above 32 weeks, there would be complications, and how many percentage and breastfeed. What I wanted to get the answer from you is that even if I have to say how many percentage I assume like will not be able to have exclusive breastfeeding based on the early breastfeeding or this concern, because people the myths about the cesarean and that we can be able to take it off, the myths about low birth weight, the myths about. So you think it is going to be a very small proportion who would actually not get early breastfeeding? Am I right?
Dr. Neelam, actually, first the myth of cesarean section, and we have seen through the data, through many cohorts that studies that we have done, that the cesarean does not emerge as the risk factor for breastfeeding failure. That's
Yes.
point one. Point two is that when the babies are born very preterm, often the mothers are also sick, right? And the babies are in the NICU or SNCU, that separation and the anxiety of the illness that have strong negative influence on breastfeeding. So it requires the huge amount of support to the mothers in terms of counseling, in terms of taking care of the mother, and mothers are able to take care of themselves, their nutrition, sleep, and their ability to express milk and kangaroo mother care. So these are, and of course, if we are trying to minimize the separation through MNCU, that is also helping in a big way. So if we take care of all these factors, the likelihood of feeding failure is low. Uh, my guess is that the majority of the women should be able to supply enough amount of milk. A recently concluded study, we worked on all these principles, and most of these mothers were making milk to the tune of 600 to 700 ml. Apart from taking care of their own babies, they are actually donating to the milk bank.
Yeah, so my question to you would be that means if we are able to focus on expressed breast milk and kangaroo parent care, then we should be able to do this better. So if you were to redesign, would you not want to do that?
Uh, yeah, you're right. These are the two very important components that expression and kangaroo mother care. But I would really like to add two more components to it, and those are
I
really
didn't
very
say mother
important.
care. I wanted to say parent. I want the
Huh.
fathers to pitch in.
Parent care, yeah,
Yeah.
for sure. Grandparents and the father and everyone. And to that, I would really like to add, and that's very, very important for us neonatologists, is this taking care of the mother. That unless you take care of the mother, making sure that she is eating, drinking, and sleeping well, her pains are taken care of, her, worries are taken care of, away from the family needs to provide support. It has to be the holistic care of the mother that would turn the tables.
Great. That was very, very useful. Thank you very much. I think that message is very clear to you. Please move on with the new. And thank you because, of course, we had the consensus together where we fought what we put the maternal care in it. As you remember the 4 recommendations that you came out with, cesarean doesn't make a difference and in that. But I wanted the pediatricians to get long and care. And I would take bites of your videos and project it everywhere. That I think this is the way to progress because nobody talks about the expressed care so much. I mean, maybe it's a myth in me. I need to get my myths out as much. I thought it needs to be talked about in the expression of the breast care because when I get fellows and residents, nobody is talking about the expression of breast milk. So with due apologies, somewhere our teaching on talking about the expressed breast milk is going low. So I thought if I had to talk to the to the administration from the ministry, I would focus on a couple of things like this. And yes, it would be nice that we present and put this paper together to them. Thank you so much. Over to
Neelam, if you can give me a moment, I wish to make another point, and that point is the same point that I made on that day also. That our problem is weak implementation. There is a huge gap between what we say and what we do. I think all the things that we need to do, unless that reach to the families, they carry no meaning whatsoever. So each one of us must make sure, and particularly, the senior people, we may not have what's happening under our nose. We may be totally unaware of the ground realities. So, go and immerse at the level of ground and find out the ground realities and try to remove the barriers that the front line, that the people at the ground level are facing, whether they are residents or your medical officers or nurses or, the frontline health workers in whatever setting you are working. Unless you remove this implementation gap, for sure we would continue to stay where we are today. I finish my
Yeah, thank you. But that's what you need to come out with the model, how you would do that. How will you get into the ground realities? How would you do that? So that's what I'm expecting you to make a paper out of it and share. Thank you so much for that. I know I have just been, as an outsider, not being a neonatologist, I wanted to put this in your court and, shoot on your shoulder that how you would be able to get the ground realities, because Dr. Paul always says that line which you said, Neelam, it's always the ground. But what is it that you as an administrator would change in the ground is what I thought, because there's no dearth of funds there, and how do we do training? And I think having a lactational expert every way may help in the long term life, so that they know what is their job. Thank you so much.
Thank you. Thank you very much.
Thank you, sir. Thank you, ma'am. Going on with the questions. The third question is for Dr. Charulata, ma'am. Ma'am, are you there?
Yeah, I'm very much here.
Yeah. Yes, ma'am. Your question is, ma'am, delayed secretory activation is common after cesarean and in diabetes, obesity, and PCOS conditions. Should obstetricians be identifying these women antenatally and flagging them to the pediatric team? And is antenatal colostrum expression from 36 weeks something you would endorse in our Indian practice?
All right. So just now we just heard a slightly different comment from our earlier speaker, from Dr. Ramesh Agarwal, saying that post C-section there is no significant delayed secretory activation. But what we as obstetricians realize is that probably the woman has been in labor for a long time. She's just undergone a surgery, and so although the secretions may be there, it is probably the family, sometimes the doctors, who feel that the lady should be resting a bit, and the breastfeeding can start later. Although we are all now, as through the Foxy, through Manyata initiative, we are making sure that the baby gets as much skin to skin contact, and early initiation of breastfeeding, whether it's after a normal delivery or after a C-section. So we per se latch the baby to the mother's breast in the operation theater itself while the closure is going on, so that the process of stimulation of the secretion starts, so that the suckling starts, which is such a natural instinct of the newborn. So per se, I think it is that the patient, the family, the doctors, the paramedical staff all need to be on the same page, that although she has undergone a C-section, she can always be assisted to breastfeed every 2 hourly. But yes, we do see that most girls are very unwilling to even move a little bit, to tilt a little bit, although we ourselves take the baby to the breast. Our paramedical staff is helping them out, but they can sometimes complain of pain, sometimes inability to move. So, just making the girl stronger in the antenatal period itself mentally is what I would say. And, letting her know that even if she has a C-section or a normal delivery, the skin to skin contact has to start as soon as possible, and the latching is going to occur as soon as possible, and that she has to try to do the exclusive breastfeeding, whether it's a normal delivery or C-section. So I think that it can be done, even whether it's a C-section. Now, whether diabetes, obesity, and PCOS, these have been listed as reasons in the textbooks, wherein you can have a delayed initiation, or you can have as what do you say, as challenges to breastfeeding. Per se, not every obese girl, not every PCO girl, not every diabetic woman is going to have this problem. So I per se feel that if I flag my pediatric team about this, if my patient is told beforehand that she has these problems, and so she could have a problem with the breastfeeding, she's going to go on an immediate back foot, and already she's a little scared about the process of breastfeeding, and if you tell her that you may have a problem, then it's just going to sit in her head, and I think we would be doing much more damage than good. If we, just like for flat nipples or inverted nipples, usually most of the times they're not true inverted nipples, and if you tell her that, oh, you may have a problem, that kind of stuff, then that poor girl is going to go on a complete back foot. So I personally would not, want to flag my pediatric team, or I would not want to raise this doubt in her mind, that that she will probably have a problem with breastfeeding. Believe me, with good counseling, with a good every 2 hourly expression, with a motivated mother and a motivated family and a good paramedical staff, I think we can kind of overcome these problems. Yes, I'm not saying that these are not barriers to breastfeeding, but they need not be told beforehand. And if we take adequate care, that woman does a good job with breastfeeding also. Now, regarding the antenatal colostrum expression from 36 weeks, uh, we don't really do it in our Indian practice. But I have many girls who come from the US or from the UK, and they tell me about this phenomenon wherein they have any drops of colostrum. They're given these sterile syringes. They're not the usual syringes. Also, believe me, they have a very good, a very nice stopper to them, and they are encouraged that if they notice some leaking from the breast, if they notice discharge from the breast, that they can have a gentle massage of the breast and collect those few drops also, and keep it in the freezer with the date marked on that particular syringe. I think it is a fantastic idea. I think it is a great thought process that you start saving for the rainy day. Like when we know that the initial time the colostrum may be a little less, or she may be a little weak and tired after a C-section or even after a normal delivery, then this express colostrum can be of immense help. But what I feel is that you need to have the correct kind of syringe, because the routine syringes that we get is probably, with a needle at its tip. We don't want to injuries to anybody. And if you don't have that needle at top, then you're not going to be able to seal the mouth of the syringe. So if you have good syringes which are meant especially for this kind of breast milk, I am happy to provide them to my patients. And as you rightly said, it has to be done after 36 weeks, essentially, because even if she has a little bit of discharge at 32 weeks, we don't want to massage the breast too much. We don't want to express the secretions too much at that time. It could give rise to some kind of contractions unnecessarily. So after 36 weeks, it is a good idea that I would definitely want to recommend this, because this is not something that we routinely do in our Indian hospitals. So this is a good practice, and we can get good colostrum when the mother is not producing too much of it, and she has a positive thought at the back of her mind. Even if I don't get too much colostrum just now, I have something stored in my freezer which I can use for my baby. Obviously, the policy is that the one which was expressed the earliest gets thawed the first, and once you thaw it, you're not going to reuse it. So this is something we can definitely start using in our Indian practice.
That was very informative. Thank you. Did you all in Foxy create some videos that need to be circulated among the members? So
Well,
maybe as a good idea, with your permission, if I may share, that like since we decided to make it like, a tsunami of messages to
Why
our
not?
team, maybe you could take because Dr. Bhaskar always says that and the other lady also who's into lactational, if you all can create some videos which you send it to your members, and that will be great. And if that could be one of the first steps where you are just training in case the healthcare professionals, others are not there. I mean, both needs to be trained. I think
Right.
first we need to look in our own family, that is the healthcare professionals in terms of doctors, with the pediatricians, neonatologists, and the gynecologists. First, we need to train these people before I mean, because you can't have lactational experts for 23 million people, it's beyond imagination. So I think it needs to be capacity building presently.
Dr. Neelam, I would just like to highlight that we came forth with the good clinical practice recommendations in 2023, and we have circulated them to all our members. We have it published in a journal too, and so we have the Breast and Puerperal Health Committee of Foxy, which is has been started more than 20 years back, and that is something very encouraging, because although our obstetricians may not be lactation consultants, But through this committee, we do a lot of promotional activities, and we encourage our obstetricians to understand about the process of breastfeeding, the early initiation, the skin to skin contact, and of course the delivery onto the mother's abdomen, and most of the things that as an obstetrician, because as you rightly said, we are the first point of contact. And so unless we are aware of all these things, we it will not percolate forward. So yes, we shall even make good videos and circulate them as suggested. And of course, we would like the position paper also, so that would be a big milestone.
Thank you so much for that, Charu. You've been brilliant.
Thank you.
Yes, please. Next, Chinman.
Thank you, ma'am. Next, we have Dr. Taruchaya ma'am, who is eminent obstetrician and gynecologist, mainly in lactation supporting. And she's a consultant and director at Bansal Hospital, Jaipur. And she's West Zone coordinator in the BEST committee. I have a question for you, ma'am. If you recommend one national policy or practice change to improve exclusive breastfeeding rates over the next 5 years, what it would be and why?
Before thank you so much, Dr. Neelam and Dr. Charu, for letting me here.
Thank you.
Before starting saying something regarding some positive notes, I must say what policies are still they are prevalent in our country. Like we are working on IMS Act, we are working on MAA, Mother Absolute Affection, and Infant and Young Child Feeding Act. There's so many policies are already going on. But what lacunas these policies are having, that is more important to understand. Only then we can recommend some improvement on that. So, in my opinion, um, breastfeeding rates in working females are less because maternal benefits are given to those who are under the cover of MMS Act. But those 80% or more than 85% females are working in those conditions where they're the unorganized sector, they're employed and uninformed. So they are not getting any benefit out of it. How can we benefit them? Is like Pradhan
Dr.
Mantri
Taru, all
will
this
now.
was discussed. All this was discussed. Can you give us short answers? Because at 5 I have to.
That's what I'm saying. Ki Pradhan Mantri Vande Yojana, so that is given to only MMS. But if the cash transfer is given to those mothers who are working and not in those cover of MMS Act, so they will be benefited and they will do more breastfeeding because they are helped monetarily. And dusra, ASHA workers and those who are training in fields, they are not tracked properly because we need some digital, be it the era of AI. We can easily track them, they are properly working or not, and what is the roster, they have really trained them or not. So this is very important to understand that is the only thing we can improve upon.
Thank you, ma'am.
In the next 5 years, if we add some digital tracking system on that, then we should know they are being trained properly because we are training ASHA workers. But ASHA workers are doing their work in the field or not? The roster is properly maintained. Is this correct? We have to compare at that level in that proper village whether this has been done and that is compared in their registers. This is also very important.
Thank you so much, ma'am.
Yes, that was useful. Thank you so much, Taru. That was very useful. Thank you.
Moving on to the next question. Next question is to Dr. Gitanjali ma'am. Although institutional deliveries have increased significantly, early initiation of breastfeeding is still suboptimal. In your opinion, what changes in labor room practice could have the greatest impact on improving breastfeeding rates?
Good afternoon. Thank you, IAP, Dr. Neelam, Indian Nursing Council, for giving me this opportunity. Being a nurse, I'm feeling proud to present Indian Nursing Council at this platform. Related to this question, I would like to say if institutional delivery would have increased breastfeeding, the breastfeeding rates would have been much higher. So we need to take some active efforts to ensure the early initiation of breastfeeding in the labor room. That's the golden hour principle should be kept in mind. So first thing is uninterrupted immediate skin to skin care. As we all know, WHO has recommended that skin to skin care immediately after birth, both in vaginal as well as cesarean section is important, and all the stable preterm and low birth weight baby should receive uninterrupted immediate skin to skin care. Although there are certain barriers to it, and there are many benefits to it, like it helps in early initiation of breastfeeding, it improves milk production, and it strengthens mother milk and also strengthens mother and infant bonding. However, there are certain barriers to it, and to overcome those barriers, the first thing I would recommend to deliver all the babies on the mother's abdomen and shift the baby immediately in between the mother's breast as early as possible. Second thing, I feel sometimes infrastructure and workflow are equally important. In many labor rooms, the mothers has to be shifted immediately after delivery because of the delivery table is needed for the next patient. There are sometimes two tables, there are sometimes only three or four tables, and mother has to be shifted. In that scenario, providing adequate delivery tables or ensuring labor delivery recovery beds that allow mothers to remain on same bed throughout the labor and delivery and postpartum can be helpful. And in situations and our setups like if we talk about PHC, CSC, where such facilities cannot be ensured, at least a trained companion, birth companion should be allowed. WHO has already recommended many benefits of birth companion, and we should start training them from conception throughout the antenatal period, and they should be trained how to support the mother, how to hold the baby in skin to skin contact, and how to initiate breastfeeding. That can help us in long run. Second important thing is cesarean section delivery. The skin to skin contact and breastfeeding in cesarean section delivery is always many a times a delay. So I think there requires a coordination between the team, and there has to be a specific protocol in each hospital for initiating immediate skin to skin contact and breastfeeding in operation theater itself. And in any case, if there is some delay, always breastfeeding cannot be initiated. Mother's own milk should always be prioritized, and the expression of breast milk should be done within 1 to 3 hours. And we need some designated team member to do that and encourage mothers to do the same thing. Second thing I feel in labor room is to delay all non-urgent procedures. There are many non-urgent procedures being performed in the labor room, like weighing the baby, sometimes cleaning the baby, routine measurements, food taking footprint, giving vitamin K to the baby, and these all things, they interrupt the situation of the golden hour. So a third important thing I would like to highlight is competency based training to the staff working in the labor room, and all the staff should be aware of 10 action plans to improve on mother's own milk and ensure mother's own milk supply, ensure breastfeeding, especially if the babies are stable, and if they are not stable, at least ensuring the mother's own milk. Then fourth important thing I would like to highlight is having standardized breastfeeding protocols with a baby-friendly hospital initiative being implemented rigorously in the hospitals, which is at present is not implemented in all the setups. Then fifth important thing is coordinated labor team, including lactation counselor and lactation support is important in all the labor rooms. One of the important things is to listen to the mother. Many a times we healthcare providers do not listen to the mothers. We do not listen to the actual problem. I would like to quote my own example. When my baby was delivered, she was 36 plus 3. She was sent to NICU because of some issues. She had bradycardia. What happened with me that I shifted I when I was shifted to the nearby place with my baby, that baby was not suckling effectively. She By looking, when the lactational counsel, the PHNOs, when they come, the neonatologists, when they come, it felt that the baby is suckling effectively, and they started scolding me that, you being a healthcare provider, you are not promoting breastfeeding, you are not they didn't listen to me. My baby was not able to suck effectively. She was on my breast, but I was not feeling that suction pressure that the baby must have applied on my breast. I was discharged. My baby did not gain weight for one month. The urine output was less, and I again turned back to the hospital with my baby, and then formula feed was started. So it is important that we listen to the mother. We address her concern. Every mother has unique challenges, and that need to be addressed. And seventh important point I would like to say in context to the labor room is quality improvement training for all the nurses. And like in Lakshita program, the quality improvement training is going on. We need to embed the baby friendly hospital initiative into that, and the nurses should learn how to help improve quality of breastfeeding, how to increase the breastfeeding rates, and they learn and bring about something in a positive sense. And then a trained birth companion, as I already mentioned, we need to train them starting from antenatal period itself. So these are all points I feel are important in labor room to increase the breastfeeding rates.
Thank you, ma'am. Thank you, ma'am. Moving on to the next question. Yeah.
Thank
The
you,
next question.
Gitanjali. That was very useful to get a perspective from the nursing. And I really loved your confession about the two things, how you can delay few things which you need to finish for work, and the competency-based learning. That was very useful. Thank you.
Thank you.
This question is for Dr. Prashant, sir. As neonatal care continues to evolve, do you foresee a shift from achieving survival to optimizing long-term neurodevelopment through breastfeeding-centered care? Which interventions do you think will have the greatest impact over the next decade, sir?
I'm very pleased to have Prashant here, who's representing the
Chinmay, thank you.
pediatricians.
Madam, Neelam madam, what are
I
you
said
telling?
we are very pleased to have Prashant here, who's
Thank you,
representing
madam.
the
Thank you.
pediatrician, and we moved on to understanding the neonatal, the issues from a newborn specialist and the nursing care in Foxy. And now what the deliberately this is focusing beyond that. And it is so important, the need of the day today, which none of us have been talking about. So we congratulate that this question, which is talking not only why breastfeeding is important for survival, increasing your reduces the morbidity, mortality, but we want to just say, how can we produce brilliant citizens? So nothing better than this. Thank you so much, Prashant, for
Thank you.
taking
Thank you,
this.
Neelam madam. So now we have India has established SNCUs across all the district and subdivision. We are able to, bring down our neonatal mortality and early neonatal mortality rate. But at the same time, we are seeing, we can say, flood of preterm babies in the district early intervention center, DEIC. That shows that there is something we need to work upon for intact survival of these preterms, which we are able to save in the SNCUs. So interventions, there is definitely, if we see the data of SNCUs across the country, the follow-up of these discharged preterm babies, it is hardly 10 to 15%. So these 10 to 15% only come when we do their ROP screening, their BERA screening, their cognitive screening, their speech screening. and we are not able to catch those 85% of the babies, preterm babies who have been discharged, who are surviving. For that, there are a lot of intervention by the government, like the home visit by ASHA, home visit by ANM, the immunization during immunization to take care of their intact survival. But at the same time, still there's a long way to go, long way to go. So I feel if number one important thing is that this follow up at the home should be done by the nearest trained A&M nurse or development professionals, developmentally trained nurses who are in the CHC or in the PHCs. Now we have a very good network of PHC and CHC. Along with that, digitalization through these WhatsApp groups and through the Anmol. There is a software of Government of India, Anmol, ANM online. So through these gadgets, we can also screen and we can follow up these preterm discharge babies, because we have data in the SNCUs and 80% of the preterms are treated in the SNCUs. Only in the metros, what we see in the private hospitals, in the corporate hospitals, it is hardly 10 to 15%. So the intervention for intact survival will be one of the, my suggestion will be for a digital follow-up through the Anmol and home visits by ANMs. Number two is that mandatory screening of mandatory newborn screening in all the SNCUs. In some SNCUs like, Kerala, Tamil Nadu, and some part of Telangana, they are doing it. It is mandatory for newborn screening in all the government setup. Whereas most of the places, they are not able to implement it. So that is one. Second is, if we have an example of Kerala, they are able to, their exclusive breastfeeding rate, their initiation of breastfeeding is, they've crossed 80%. Whereas we have other states who are struggling in 50%, 52%, 48%. So that means it is a doable thing across the country. And another one thing I would like to add here is MCNU, mother
Where
and
is the
child.
speaker, Pavan, in this?
Dr.
Pardon?
Sushma, can you mute yourself, please? Sushma Malik, please mute yourself.
One is MCNU, Mother and Child Newborn Unit. So in Safdarjung, they had a implementation research by MCNU. They have implemented where mothers were kept in the NICU along with the baby in the rooming in as a rooming in. So it has been observed that those babies who are with the mother, so there was time for counseling the mother by the gynec obstetrician as well as our pediatrician neonatologist as well as the nurses. So that was creating a very positive impact on the mother to take care of the baby through KMC, through massaging, through the development supportive care, like by decreasing the illumination, by decreasing the sound, by minimizing the screen time or zero screen time. So these were the steps which was taken by the mother even after discharge, and also the follow-up rates have increased. So that model was done in some of the states like Himachal Pradesh. Simla Medical College took this initiative, but there is a long way to go, and we need to implement this in across the country, which will go a long way for intact survival of our newborn babies. Thank you, Chinmay. Chinmay, you are mute, I think.
I am Prashant. That was wonderful. We would love it that since there was no presentation, if you can put this and I will connect you. Actually, there is a need where we are talking about the first 5 years, what needs to be done. So I'll sincerely appreciate if you can just write a summary and we'll put you in a group where we're just planning to have this group which is going to look into the development roadmaps and what needs to be done. So that is for the developmental people, but your suggestions for this preterm, which was useful, will go a long way. So I kindly request you to share this and your contribution obviously will be acknowledged.
Thanks a lot, madam, for opportunity. Thank you.
Thank you, ma'am. Thank you, sir. Moving on to the last question. Yeah. Dr. Rupal ma'am, why India is falling in breastfeeding in the context of NFHS 6, and what are the universal myths regarding breastfeeding and babies' growth, and what actions can be taken at individual level, at hospital level, ma'am?
Okay. First of all, I would like to thank Dr. Neela Mohan, my favorite. I love her sarees, so I'm going to take those. So, and another thing is my introductory slide had a problem. I think I had sent the one which I had, appeared for a faculty at ICMR for one of the conference, and I think we have forgotten to remove that logo of NSI and ICMR. So just make sure that it is removed.
Sorry, ma'am.
Yeah, that's okay. So again, I'm I'm a pediatrician, and my focus is really
I
public
would just
health.
like to introduce to everybody, we're very grateful to
Yeah.
Rupal, and we apologize. The question was third, but I guess in that, Rupal I would take her as a public health expert in today's thing, because though she lives in USA, but one of the first time I got introduced to Rupal was when she did a paper on malnutrition, and it was quite interesting to see how this lady looks from the west and the east and divides her time. We're very grateful to you to always been talking about the metabolic health. And since you talk on metabolic health, we thought that the latest things which talks about how breast milk is going to be important towards metabolic health, it's a part of the journey that you're talking about. With those context in mind, we would want you to speak this. And thank you for joining us in middle of the night at 4:30 a.m. in USA. Shatak Pranam to me for being with us. Over to Rupal.
With your permission, Madam Neelam, Madam, with your permission, just one sentence about Rupal. She is the first lady whom I met who told that it is a myth by the Western countries that the short stature and thin build, it is a fact about the Asian people. She told that nutrition can change, and good nutrition means all the Indians will be of good height, good weight, and healthy. So thank you, Rupal, for changing my
Beyond
concept.
her and say foreigns. Neelam says it's not nutrition, but nurture and neurodevelopment. Foreigns will change the height. Thank you.
Yes. Okay. So just a little bit of context. For past 20 years, I've been working in India predominantly. So I spent time just 3-4 months in US. But my experience has been that I've worked in US for 25 years. And so I continue working in US also, and 20 years in slums of Mumbai, and now many states of India. So let me tell you about why we are failing in breastfeeding in context of NFHS 6. Now, as Chinmayana mentioned about NFHS 6 reduction of exclusive breastfeeding, what is lacking in India is lack of skills. Okay, skills are lacking in workforce. They're lacking in doctors, nurses, mothers, everybody. Okay, and what happens when skills are lacking? Doctors and nurses are compelled to choose inferior solutions. Okay, inferior solutions. What are they? Formulas, breast pumps, nipple shields. Poor mothers, they opt for cow's milk. So there is too much of prelactal going on. Okay. Now it may seem useful in a short run, but it harms the nation in a long run. So it's destructive to nation's future, right? You don't want your children. And I come from that society where if babies are not gaining weight, they immediately started on formula. In US, the exclusive breastfeeding rate is very low. They also give a lot of breast pumps. They give a lot of nipple shields in this country, in US right now, and unfortunately, that is causing obstruction to exclusive breastfeeding. So I think what we need to really do at this point is to, as Dr. Neelam mentioned, that we have to train everybody, including mothers, family, everybody. Okay. Now, for that, what we have done at IIT Bombay, we have created tutorials, which I'll talk later. But let me just discuss about NFHS 6. Now, problem is that stunting is reduced. So if you look at NFHS 6, stunting is reduced, but is it good? What I'm saying is Probably not, because now the stunting reduction is happening because of giving formulas to babies. So you don't want to reduce stunting by giving formulas, because what we are seeing in US is I'm seeing too many of this atopic dermatitis, allergies, asthma, a lot of autoimmune conditions. So I'm hoping that India should not head like how US and UK are doing. Okay. Another thing is that there is a goal set for 2047 by Honorable Prime Minister of India on Atmanirbhar Bharat. We will not be able to achieve. Okay, because there are various skills which are missing. I'm not just talking about breastfeeding skill, but there are also skills missing among doctors: how babies should grow, how they are developed, how to read WHO growth charts. In US, if I did not plot WHO growth chart in first 2 3 years, I would be blacklisted. I don't see that happening among pediatricians. So I think that's important. They need to know one myth that I'll be talking about it, because people are not plotting those WHO growth chart. They don't know what happens in first 1 week of age. Okay, so I'll come back to it. We are also not a faltering centric program. So what happens when the baby get discharged in US? Within 24 hours, baby is seen by pediatrician, and the baby is seen by pediatrician every 24 to 48 hours on weight check and jaundice check. So weight check is why, because we do look at whether mother is able to breastfeed or not. And if they're not able to breastfeed, if the weight gain is not good, and our cutoff is very good. So our cutoff over here is 30 to 35 grams a day. Okay, right from literally from 48 hours, after 48 hours, if babies are not gaining 35 to 40 grams a day, those babies are requested to come back again or are sent to a lactation consultant. But we don't let them go just because saying that, oh, mother is breastfeeding, and we do monitor the weight gain. Okay, so I think what we need to do is to, rather than having a wasting centric program, this is for policy level, we need to look at faltering centering. So if the child is faltering right from day 3, that's an issue. There is no focus on growth catch up. So problem is that uh, again, because there is no focus on growth catch up, so a child is continue to say stay on third percentile or even 15th percentile. They feel, oh yeah, this is okay, it's not okay. And I'll again come back to what action is to be taken by individual doctors and hospital. So what are the universal breastfeeding myths? The most important myth that we have in India, that baby lose weight in first week. We don't have this myth in US. Okay, baby don't lose weight in first week. They gain 200 grams in first 1 week. First week, boy child gain 200 grams, girl child gain 100 grams, and this is by WHO recommendation. So these babies were breastfed. Okay, so please, we need to remove that myth. They need to start gaining from day 3 of life. So again, I recommend to for healthcare workers in the delivery room, or wherever babies are admitted, or in PNC ward, they need to have WHO growth chart, which has weekly update or even daily update. Another thing is 500 gram per month cutoff. That cutoff is too low for India. We don't have that cutoff in US. We have cutoff of 900 grams. So almost 1,000 grams cutoff we have. So we need to remove that, and we need to say that minimum 30-gram weight gain per day starting from day 3. Another myth we have is breastfeeding is natural, so it's instinctive. So, they don't focus on the skill. I think it's important that we focus on the skill. C-section mothers don't get milk and starting formulas right away. So a lot of the C-section mothers are given formula ka dabba right there, even in district hospitals. So I think that myth needs to be cleared. Mid-parental height. I think this mid-parental height needs to get away with. Dr. Neelam, please work on this. In US, you will see all these Indian children are really tall. This are again breastfed in Indian diaspora over here. They are much taller than what I would see in Indian children in India. So it's mid-parental height needs to get away with, because what happens when pediatricians think that, oh, mid-parental height, it should be this, so they don't focus on the skill in first 2 3 months. That's when baby is growing very fast. So I think that we need to understand that growth catch up is very quickly in first 3 months of life. Now, another thing is, if the baby is growing slowly, if the initial milestone says baby smiling or a little bit moving here, there, or, say even rolling over, so pediatrician feels that baby is fine even if there is no growth catch up. I think that is a big concern for me, because if there is a good milk transfer, if the techniques are really focused on, these babies grow very well. And I have plenty of data that we have presented. In fact, right now our project has been taken in a program mode by Meghalaya government, and they are going to focus on each and everything, and we are collaborating with John Hopkins medical colleges, and they're going to do implementation research for the state level. So I'll talk about that later, Dr. Neelam, whenever we have time. Another thing is lack of understanding the length in its first 3 months. So I think please focus on milk transfer in first 3 months, because that will really improve length in children. And we want stunting to reduce by breast milk and not by formulas. In public sector, I recommend Dr. Vinod Paul. He knows my work, and he's also recommended to do IR, implementation research in Meghalaya. And I feel that faltering should be really tackled very quickly. Do not wait for too long. Do not wait till baby goes into SAM, severe underweight. Tackle it as soon as within 2 days, 3 days. If the breastfeeding or the faltering is occurring, immediately and tackle the issue. Where should be the action taken by individual doctors, hospital, and country? I think let me discuss that. Individual doctors, please get trained in just basic understanding of breastfeeding skills. It's basic. IT Bombay has come up with 45 points of counseling. Very simple points. If you know it, your baby will just do absolutely amazing. Okay. Another thing is train ANC mothers. So you train those ANC mothers. We have Lamaze class in US. So please start those Lamaze class for India also. Get those mothers learn breastfeeding skills, not just mothers, as one of the panelists said, that train mother's sister, mother, everybody, even husband, because when we train these techniques in district hospital, fathers are very, very smart. They understand the mechanic of skills very well. So please train them also. I would like that all the gynecologists are trained on breast crawl, and not just breast crawl for vaginal delivery, but also skin to skin in the OR during C-section. So I think that is very, very critical that this gynecologists are trained. We have again created tutorials on how to do during C-section, how to do breast crawl. To train all the staff nurses on different holes and positions. Okay. And this also includes, we have come up with something called Singroli hold. Now, Singroli hold is very, very powerful, and we are using it. We are training nurses in public health. This is for C-section mothers when they cannot even turn on the side on day one. Singroli hold has really shown very powerful results. Another thing is introduction of breastfeeding assessment form. So what we have created at IIT Bombay, we have created modified breastfeeding assessment form, and Meghalaya government is taking up this for each and every staff member. I would say about 22,000 healthcare workers are going to be trained on breastfeeding assessment form. This way, what happens, by the time mother is ready to be discharged from PNC ward, she is updated on each and every point that we like them to know. And before she get discharged, I do recommend that this mothers need to have a scoring system. Okay, so nursing in charge, or somebody who has taught the breastfeeding technique, but somebody who is superior or supervisor, can basically look at whether mother knows few important points, and we have created a scoring system. So please feel free. It is an open source, and Dr. Asha ma'am has, everybody has. So use that scoring system before discharging, so that way you know that mothers are empowered. Another thing is, if the scoring is less than 90, please request mother to stay one more day, because once she get discharged, it's very difficult to get that mother back in the hospital, or back in the NRC, or back wherever, to teach those techniques. So please make sure that scoring is done, and don't discharge that patient till the scoring is 90%. Now, frequent visits in first 2 weeks of life, because that's when mother is learning, baby is learning through baby's gaining weight through milk transfer. So more visits are needed, just like how we do it in US. So I think let's look at, that consistent weight gain of 30 to 40 grams per day. Until that, keep doing the visits every 24 to 48 hours. Another thing is to plot percentile growth chart. So I request, all the doctors to at least learn about growth chart and how babies grow. There is a recent guideline which came from India. Samagra guideline correctly identifies newborn who have not received breastfeeding as a high risk babies. Now if you look at my experience of working in all these hospitals, 90% of them, believe me, are getting some kind of prelactals. That means they all are high risk. So I would not look at only high risk baby. Every baby is a high risk in India. Okay. uh, Again, another thing for country, and this is for Dr. Paul, and I have mentioned to him earlier also, the growth chart that we use in government setup, it's basically flawed. Okay. And I'm not afraid to say that, because what they have done the zoning of WHO standard deviation chart. Now zoning is green, yellow, and red, but the zoning is only from median to -2 standard deviation, or below, from median to below my negative standard deviation. There is no zoning, that is, there is no green zone between median to +2 standard deviation. So what we are trying to do in government system, we are basically keeping our children below median and saying this is normal. It's not normal. You have to have a zoning between -2 to +2 standard deviation. That green zone needs to be there. And I do recommend using line growth chart, which is recommended by WHO, because in US we also use line growth chart. We don't use zoning. Zoning is very, very deceiving, because once a child comes into that green zone, which is third percentile, people feel that, oh, this is normal, especially ASHA workers and Anganwadi workers. So I want to make sure that this has been taken care of. And please keep your target weight gain high. Don't be happy with just 15 grams of weight gain or 17 grams of weight gain, which comes to around 500 gram weight gain per month. Don't be happy, because once you have that kind of low target weight gain, your babies will never come out of stunting. Okay, so I just wanted to conclude what I was mentioning. And if you have any question, please feel free to ask. Thank you so much.
Gopal, that was
Yeah.
very informative, though I tried to note it, but there may be something I missed, and I was looking at your eyes. You are looking down. To be a smart presenter, you should make some points. So before you forget, just WhatsApp me those points. Three important points which I need to work with the policy hat. I will ensure that it is done ASAP regarding because fortunately the Joint Secretary of Women and Child directly connected me with a number and said, "This is my number, save it. Any suggestions you're welcome to give," because I think I'm blessed that it happened. And so I'm going to share her, obviously, the messages that I'm going to get from you all. And I have now adorned the public health cap with which I'm working on. But having said that, there is the purpose of having such meetings is that you could see a variety of people came around, not only right from the gynecologists who are going to deliver, to the neonatologists, to the pediatricians who's going to care, that the training nurses who are going to talk about, and in the end, a cap of a public health expert, which was Rupal. So that is what was a very beautiful thing. And I must congratulate and compliment the three things. I envisaged the entire breastfeeding program almost 2 months in Win1. And I connected Dr. Asha Banapa 6 weeks back, probably, and of course, Dr. Rupa Bella. But sometimes things happen, which is God's destiny. Dr. Rupa was very busy in her IYCY projects, and she could understand, Asha, that I wanted a very different way. And thank you, Asha, for structuring it, and then we added on to it because the groundwork was done and it was easy to subsequently add on. to this. And as you could see in the 7 days, I am so pleased to say that we could ensure the policy of workers were there and everything and the pediatricians. But sadly, we noticed that there are not many people who would want to join because they think, I don't know what they think, so it is a Herculean task, but not impossible if these 50 to 60 people who always have been joining consistently, they are the ones who can connect to me. I'm here, you all know me, so you connect and we form a group of you all, and which is going to be a part of the Breastfeeding Alliance team. And all of you all who are interested can be. And I may request Dr. Rupal to continue to do with us because there could be nothing better than helping millions of people across the country. And God has chosen us to be in this role that we can give it. So I sincerely thank each and everybody in this journey of 7 days that we have. I don't think, is there anyone I've missed who is, I assume Dr. Paul couldn't have been here, I can't see him, but I can see all the others. So at the end, I would take my privilege to thank few of them from my heart, which was I've already done for Asha and for Ganesh Kulkarni. Ganesh, you have been the spine where all these people to get in, to connect, to call. Thank you very much. Together we do the work in supply. And also all the youngsters who came and did their presentation. We had diversity in the presentations. And if it wasn't, as I said, it's destiny. If it wasn't how it clicked, how I just thought about getting this Breastfeeding Alliance together with that in a week, how we could get all this into doing. And it's so wonderful that this could happen in each one of you all who have been there. Like seniors, it was so wonderful to see stalwarts right from Dr. Armida, and so many names whom we had the guest of honors over the days. It would be beyond my scope to say, but hope, Dr. Ganesh, you've written down all of them. You can give a big vote of thanks. And I, Dr. Neelam Mohan, President, Indian Academy of Pediatrics, want to express my sincere thanks to President Bastard Park, who's the president of FOXI, Dr. Lallan Bharti, President, ANF, Dr. Dilip, the Indian Nursing Council, to believe in me and join with me together. It was not IAP, it is we together. But always when we have a group, it happens that if I have my parents living and the grandparents living, even in a marriage card, we always put the name of the senior most person and then. So maybe IAP is with the large numbers that it has pediatrician. So we have to keep them as the numbers IAP and then FOXI and then ANF. And it is not undermining the power of the nursing people who are definitely in lakhs, but the number of nurses are going to be skilled in this. And my message to one and all is going to be, as Rupal has said, the three messages. It is we assume that it is a natural instinct, which I said in the first day. That is it always a natural instinct, or there is something about a skill which we need to learn? And today we cleared a lot of myths, and I would request, especially the people who gave the lecture, all of them who were involved, to go by, to listen on the talks, get down the points, make this is challenge. You youngsters, I got you on into this, whether it is Nida, whether it is today Charunia, whom I said presidents, it is, you all are here because you are our future. We wanted you all to be on this forum, but I want you all to ensure that you see everything, make the minutes and send me the project report of this 7 days breastfeeding within the next week, because after that you all will forget. Ganesh, you're going to be the master with the ban on this and ensure all of this is AI translated and getting into it in the minutes, and so that we are able to make a report. We will send it to all of them and then make some recommendations which the pediatricians who did not listen, who assumed that they knew it all, need to understand what they need to know. Thank you for working, but that's the beauty. It is not possible for every pediatrician to learn hours and hours of breastfeeding because they think that they want to learn this specialty. But having said that, we are here to give them something as a healthcare professional. Everybody should know the basic CPR. Even if you don't know the basic life support, learn the basic CPR. Everybody should know the basics of breastfeeding. If you don't know the hard-file lactational, but that is what every pediatrician should know. The adolescent counseling, if you don't know, to be a mental health expert. So this we cannot get away with. Every pediatrician should know the growth chart importance, even if they don't know to talk about short stage or endocrinal problems. But if they know when to refer, I think we can make a big change in the country. Thank you so much, all of you, for being in this journey together. And over to Ganesh for a formal vote of thanks. If I've missed anyone, you can, but you have to get this sorted. And I've asked Sushma, though she's busy, but since she's a breastfeeding expert, Sushma has to put the next 6 weeks to 8 weeks of her grandparent role to a role of a national expert who's going to help us. And Asha is always there in a witty manner. But having said that, she's very professional when it comes to presentations. And one thing I've learned in this whole thing, one message which I have learned is the first day message from Arvida. Do not criticize. That is what I'm going to take from this entire learning. She said, and I think that's a message not only for a mother, but to our colleagues too. Let's not criticize. All of us don't have the same drop of knowledge. So she said, don't tell a mother, how did you hold your baby? Rather than that, say, oh, you've held it this way. Maybe it would be better this way. So that is what we need to learn today. Thank you so much.
Thank you, ma'am. Thank you. Your words expressed all the gratitude. It was from your heart that I could really read it. And first thanks goes to you, actually, because from day 1 to day 7, you were sitting, taking down the notes of about everything, and that I have never seen with any kind of a president before. I'm not saying big words for it, because this is something which you just thought about it, you got it into action, and not only for the organization, one organization. I know how it is difficult to get all organizations coming together, making one particular program. It is beyond words. I'll tell you, it is the most difficult task, because I was doing it, and I realized that in one organization it is difficult to get one program. Getting 4 organizations and getting a program which runs over 7 days, it is practically impossible. But you put your heart into it, and I could see 4 a.m. messages from you, I could see midnight messages from you, everything about breastfeeding. So first thanks goes to you. And then definitely all the stakeholders from Foxy, Bhaskar Pal, Dr. Charulata ma'am, they all were phenomenal, helping me around and being part of this journey. Second is definitely NNF. Lalan sir was always there on, every time he used to put up a message. He showed the interest that yes, this should go ahead, this should go on, this alliance should remain there forever. And then definitely I was surprised by Dr. Dilip Kumar sir. That's an organization with 14 lakh staff nurses, which is such a huge number of expertise with us. And he was so instrumental in giving all the support. Dr. Sarvajit Kaur madam, she is the secretary of INC. So first thanks goes to all of them. Then definitely Asha Benkappa ma'am, without her mentioning her name, nothing can happen. I think she's really been so kind and generous with us to support us continuing this program. Then definitely all the faculties. I being a pediatrician practicing for more than 25 years, I never myself had such an importance about breast milk. And, but at the end, I thought that, I should go back to 25 years and restart my practice, because this is what I have missed for so many years. I did not put my, counseling art, counseling these mothers. So I was in a different direction altogether. But I think youngsters should take something out of it. And I know Sushma ma'am would be there with me. We would come out with some positive aspects from all these lectures. And all our phenomenal chief guest of honors, everybody was so, they all are so stalwart in their own work, in their own field, and they were there attending each and every module. That was awesome. That was really awesome. And top of it, I would always thank my leadership again, Dr. Secretary General, Dr. Ruchira ma'am, Dr. Singarvel sir, Dr. Alok sir, all of them. They all were so supportive to this module. And then comes the technical team from my side, Dr. Mr. Saji, Mr. Mayank. They all, did a wonderful job getting everything under one scale. And then on top of it, as you rightly said, these 60 which I have seen attending each and every day from day 1 to day 7, that shows that, they are the ones who want to.
Request all of these people to please write what you felt, what I did or what we did, because the problem is negative news spreads so much in all the WhatsApp of IAP, which disturbs me. One thing it goes, I can't believe they will go like anything as if some murder has been done. But when it comes to positive news, where are we going wrong? Have you ever seen? So I request all of you, the people who attended, to write a format of what you thought, what you felt, so that we compile your messages and make a master message and send all of you. So all of you gather, send a message with your name. And you can send that message, whatever. My email, drneelam@yahoo.com. Ganesh and me will compile your messages, because like so many people are there whom I cannot go on, whether it is, everyone who's writing. And I think I will take a leave now. I have to get into another meeting. Thank you so much. And Dr. R.K. Anand, we gave him opportunity, but he wasn't able to communicate. We all realize he's one of these stalwarts. So we did take his name. We salute all our seniors who are there, but the reins are in the hand of the youngsters who were involved in this. I did my job only as the president of IAP, but it is the entire IAP who stood like a pillar. And I would like to, as you said, thank my OB and EB always for this. Thank you for this. Have a great day. See you all. Bye-bye. Post and send us the messages so that we send the messages across the country. Thank you.
Thank you, ma'am.
Thank you.